And this is going to be a pretty informal talk, so if you have questions during, you can raise your hand and I'll try and address them, or if you just want to save them to the end, or there's going to be a segment where we're showing you some video and that'll be for some downtime for us to answer any questions that you have that come up along the way. But specifically tonight, I'd like to talk about prostate health and more specifically prostate cancer. So the first question that may come up is what is the prostate? So here's a diagram of the male anatomy from it's called a sagittal view. It's kind of cutting down the middle. And we're pointing out here the bladder. And behind the bladder is the rectum. And beneath the bladder is the prostate, that organ in red. Some structures that are important surrounding the prostate are the rectum, the bladder, the nerves underneath and the nerves and the muscles underneath the bladder that are important for urinary control and continence as well. You have the testicles. So the prostate is a male gland that is responsible for making the nutrient fluid that comes out when a man ejaculates. That fluid is important for sustaining the sperm as it exits the male and travels through the female reproductive tract. So the next step in terms of the prostate, what is prostate cancer? Prostate cancer is when these cells in the prostate start to grow abnormally and out of control, like most cancers. And the concern with most malignancies, which make them life-threatening, is that this uncontrolled cell growth can invade other organs, cause symptoms, and ultimately lead to someone's demise. You know, the unique thing about prostate cancer is, like, in contrast to a lot of other cancers, prostate cancer can exist and grow in very early stages and not cause symptoms. So it's not usually until the cancer becomes spread to other organs that males develop symptoms. Spreading to the bladder can cause difficulty voiding and obstruction. Spreading to bone can cause pain. Some facts about prostate cancer, just so you understand why this is a relevant disease, is just the prevalence of it. It's the most common non-skin cancer diagnosed in the US. It's also the second leading cause of death in men. In 2010, over 200,000 men were diagnosed with prostate cancer. And 1 in 6 men will be diagnosed with prostate cancer. 1 in 35 men will actually die of prostate cancer, and in 2010 there were over 32,000 deaths from prostate cancer. So it's a clinically significant, important cancer. It affects our population significantly if left undiagnosed and left untreated. And it's also a very prevalent cancer, meaning there's quite a significant amount of it. If you look at men over the age of 50, over 30% of men have prostate cancer. So who gets prostate cancer? Who's at risk for prostate cancer? Of course, men, because they have a prostate, but specific risk factors are age. You have a higher incidence of developing prostate cancer as you age. Ethnicity. African Americans have a higher risk of prostate cancer than other races. PSA, which we'll discuss in more detail later. If you have PSA is a blood test that we'll again discuss. But if you have abnormalities in the PSA, that puts you at higher risk for prostate cancer. Family history. So PSA is a protein that was developed in about '86 in Buffalo. It stands for prostate-specific antigen. It's specific because it's an enzyme and protein that's only made in prostate cells. So it has very little cross-reactivity or false positives with other proteins that are made in the body. So the normal range, kind of all comers, is 0.4, but there are a couple other factors that we'll discuss as well that can impact and that we should consider when we're looking at PSA in men. It varies with your age. We would expect you to have a higher PSA if you're 60 as opposed to 30. It varies with your race. It varies with the size of your prostate, and it varies with time. So age-specific PSA, these are the age groups, and these are the expected PSAs that we would see. In terms of PSA varying with time, one would expect a PSA to increase by a value of 0.75 for any year that you're checking your PSA. So if your PSA, you're getting it checked and it increases by 0.5, that's nothing we're really concerned about. But anything higher than that raises concerns. PSA density is when we look at PSA in relation to the size of your prostate. So if you have a very large prostate, say a prostate of 100 grams, we would account for that and expect a higher PSA than if you had a small prostate of 20 grams. So when we look at the PSA in relation to the size of the prostate, we note that as PSA density. So screening for prostate cancer. Since prostate cancer is usually asymptomatic in its early stages, we have a couple of things we usually recommend men consider for screening to catch prostate cancer early. It's very important. The earlier you catch prostate cancer, the more chance you have of treating it appropriately and getting past it. So the screening for prostate cancer consists of the blood test PSA and the digital rectal exam. So because of the anatomy we reviewed earlier and the fact that the prostate resides in front of the rectum, we're able to adequately assess at least a portion of the prostate through a digital rectal exam. Other ways that we can then go on to assess either an abnormality in the PSA or an abnormality in the digital rectal exam is by an ultrasound through the bottom and potential biopsies through the bottom to sample tissue. So prostate biopsy indicators to recommend a prostate biopsy are, as we discussed, an abnormality in the PSA, an abnormality in the digital rectal exam, and things that we consider when we're looking at the PSA to determine whether it's abnormal are the velocity we discussed, the age and the density, and family history. So prostate biopsy, this is just a schematic. Patients we usually have in our exam room, this is done in the office. We usually do it with just local lidocaine to numb up around the prostate. Now we have also nitrous oxide in the office, so we're able to give patients who are interested in nitrous oxide, make it a little bit more comfortable. But for the majority of guys who have it with local lidocaine, they do pretty well, and they tolerate it fine. They don't usually need additional pain medications afterwards. We do give you antibiotics and explain to you and discuss that it's expected after a biopsy to have blood in your urine. That clears up with time. Blood in your stool clears up as well. So we do the biopsy, and the biopsy specimens come back positive for prostate cancer. There's some information we're going to glean from those biopsy specimens that's going to help us in terms of determining the extent of your disease and the aggressiveness of the disease. One thing that you're going to hear in research that you do on the computer is the Gleason Score. So when those tissue specimens come back, they're examined under the microscope by a pathologist, and basically based on the architecture or the way the cells look under a microscope, they can determine whether the cells are normal prostate cells or cancer cells. And then for those cells that are cancer cells, they have a grading system from 1 to 5. 1 being more benign, less aggressive cells, 5 being very aggressive, fast-growing cells. So the Gleason score, you take the 2 most representative sections of your biopsy and you add those scores together. So a Gleason score will typically be something like a 3+3, which is a very common Gleason score that we see in more benign behaving, compared to a Gleason score of 9 or 10, which is a very aggressive cancer, fast-growing, very concerning. So with the information we've gathered so far, your PSA, your digital rectal exam, your Gleason score, we're able to do some initial clinical staging. And staging is just putting this information together to determine the extent of disease. Is this disease all inside the prostate, or is this disease outside the prostate? So that's the clinical staging we're going to go over now. Again, that's a combination of all these factors that we just discussed. So the clinical staging goes from T1, 2, 3, and 4. So clinical stage T1 is cancers that are picked up incidentally by a rise in your PSA. There's nothing we can pick up on physical exam. X-rays are essentially negative as well. So the majority of T1 stages that we pick up are T1C. That means there was an abnormality in the PSA that led us to do your biopsy and we found this cancer. Stage 2 are stages that we can actually feel an abnormality on digital rectal exam. So depending on how large the abnormality is, whether it's involving one side or both sides, it can be categorized as a TA, TB, or TC. But these are still confined to the prostate. It hasn't gotten out yet based on this criteria that we're going by. Stage 3 is when it's starting to get outside the prostate, either growing through the capsule, growing to a connected structure to the prostate, your seminal vesicles. That's where the ejaculate and sperm are stored. These would be categorized as a stage 3. And then stage 4 is when it's going outside the prostate to adjacent organs or to distant organs. That would be your bladder. If it goes to distant organs, that could be your bone. So when we discuss treatment options with patients, we're considering the stage, their age, their health, and your personal preference for the options we're going to discuss. Again, the risk factors that we're looking at to proper counsel you are these: PSA, Gleason score, the stage, and the volume is important as well. When we do a biopsy and we see how many biopsies are positive, that gives us an indicator of the volume of disease. There's also a role for imaging in terms of staging. If someone has a high Gleason score and a large volume of disease, sometimes we get MRIs, CAT scans, bone scans to have imaging further assess whether there's potential for disease outside the prostate. So treatment options for prostate cancer, and this is more comprehensive. Chemopreventative agents, things you could potentially take before you're diagnosed that may decrease the risk of prostate cancer. Active surveillance is a rapidly growing treatment option for some of those patients we're describing, some of those gentlemen who have less aggressive disease and if left alone, may not need to treat the disease. Radiation therapy, removal of the prostate. Cryotherapy is not really a large volume treatment option. There are not a lot of guys who are getting cryotherapy, but I put that up just for completeness sake. Hormonal therapy and chemotherapy. So these chemopreventative agents include things like lycopene. There was a SELECT study which looked at selenium and its ability to decrease the risk of prostate cancer. My bottom line and take on this is I think a lot of these agents are probably not going to pose any harm, but there's not a lot of strong, hard data showing that they really make a significant impact on decreasing the risk of prostate cancer. Again, it tends to be more of a genetic disorder that there's not a whole lot that we can do to affect your genes and family history. I've had a number of patients come into my office and ask me about finasteride, and does finasteride put them at higher risk for prostate cancer? The answer to that is no. Finasteride is a medication that we give to men to treat obstructive voiding, or BPH, and it's a medication that over time shrinks the size of the prostate. It affects the testosterone pathway, and usually in the course of 6 months results in about 20% reduction in prostate size, and also a reduction in the PSA that we like to keep an eye on if we're starting someone on finasteride. But finasteride in the urology literature does not pose any additional risk for prostate cancer. So active surveillance is for gentlemen who have the stage T1C, so it's cancer's picked up by an abnormality in the PSA. It's also the recommended protocol for active surveillance is Gleason score of 6 or less and a PSA of less than 10. And when we do your 12 core biopsies, if 3 or less of those biopsies are positive, and out of each of those positive biopsies, if 50% or less of those cores contain cancer, then these are the criteria we usually go by in terms of recommending active surveillance. So active surveillance consists of, we're still keeping a very close eye on you. We're going to check your PSAs periodically, initially every 3 to 6 months. We're going to recommend a digital rectal exam in that time as well. And then somewhere along 1 year from your biopsy to 2 years, we recommend a repeat biopsy to make sure none of these criteria change. Radiation therapy can be given in a number of ways, either externally. Proton beam is a new radiation modality that's gotten a lot of press in the recent time. Brachytherapy is something that used to be more common, probably in the 80s and 90s, and less common now. But brachytherapy is another option that we'll discuss in a second. So advantages of radiation therapy is it's less invasive. For those stage 2 cancers or less, there is the potential for cure. Disadvantages with most treatments for prostate cancer are going to be incontinence, erectile dysfunction, urinary symptoms. So conformal therapy uses a CT scan to image your pelvis so that you can properly target where the radiation is going to be administered. Brachytherapy are the little seeds we discussed. So we use an ultrasound. We put this template along your perineum, so beneath your scrotum, and then visualizing the prostate, we're able to place the seeds strategically throughout the prostate so that the radiation administered through the seeds is treating the prostate effectively. So this is just showing you the actual size of the prostate seeds. So removal of the prostate we can do a number of ways. It can be done in an open fashion, making an incision. It can be done underneath the scrotum in a perineal approach. It can be done laparoscopically, and it can be done robotically. The advantages, again, for stage T2 disease, it's potentially curative. Disadvantages, again, some of the same potential issues you're going to be seeing again: incontinence, erectile dysfunction, stricture formation. So when we remove the prostate, we have 3 goals. Goal number 1 is to cure you of the cancer. Number 2 is to maintain your urinary function. And 3, if you have existing erectile function beforehand, is to maintain that erectile function. So one of the things that we're able to offer with surgery is a nerve-sparing approach. So the reason erectile dysfunction is a potential side effect of surgery is because the nerves involved for erectile function are intimately involved with the prostate. They sit along the sides of the prostate where those yellow lines are demarcating the nerves. With the surgical approach, we do have the potential in patients whose cancer is confined to the prostate to identify those nerves and peel them down and just remove the prostate. So those men have the potential to maintain their erectile function. So these are just schematics showing the things that are surrounding the prostate, the bladder, urethra. We're going in, removing the prostate, and then we have to reconnect those 2 structures. In the retropubic approach, we're making an incision from below the belly button to the pubic bone. Open surgery. So the data on open surgery, things that we like to track, especially when we're comparing different forms of surgery, are blood loss. The average blood loss with an open prostatectomy is almost 1 liter. The amount of time you're in the hospital afterwards, because it is an open approach, the average hospitalization can be 3 to 4 days. And also, after the surgery is performed, your prostate is removed, we usually connect those 2 structures, the bladder and the urethra, over a catheter. A catheter stays in for a period of time to facilitate the healing of those 2 structures together. So with an open approach, the typical catheterization time is 2 weeks. The perineal prostatectomy is the same technique. You're removing the prostate. It's just a different approach. Instead of going from the suprapubic region, you're going underneath the scrotum. And the laparoscopic approach, we're doing the same thing as the open approach, but instead of making an incision, we're doing it through small 8 to 12 millimeter port sites. So with traditional laparoscopy, we're putting in several 5 to 8 millimeter port sites. Typically, the blood loss is a little bit less than with the open approach. It goes down to, instead of almost 1 liter, about 300 to 400 cc's. The hospitalization, because you don't have this big incision, you have less pain, you're able to get up and walk around sooner, is a lot less. The hospitalization is about 1.3 days. And also, there's a lower risk of infection and bleeding. Because it's done in a minimally invasive fashion, the catheterization is a little bit less as well. So one of the reasons we're not currently doing a laparoscopic prostatectomy is just it's plain hard. You're standing there, you're operating with sticks in a 2-dimensional field, which when you're doing a complex operation like a removal of the prostate, it's exceedingly difficult. This led to the development of a robotic approach. With the robotic approach, we actually have increased manual dexterity Now I'm no longer operating in a two-dimensional field, but I'm able to operate as if I was doing it open, and actually my manual dexterity is more increased than if I was doing it open. The key technology to this is just the wristed instruments that are involved with the robotic system. The instruments can move in degrees of movement similar to the hand as if you were doing it open. So this is a schematic just showing the setup in the operating room. The surgeon is on a console right next to the patient, and in this console you're looking through a high definition field. It's a 3D. The detail and precision with which you're able to operate is much higher than if you were doing it straight laparoscopically or even open. So again, in this cartoon, we're just showing the surrounding structures of the bladder and the urethra and the prostate and the nerves that are involved. So with a nerve-sparing approach, we would go in and peel those nerves down. We would then separate the prostate from the bladder, separate it from the urethra, and then we would reconnect the bladder neck to the urethra. And that is always done over a catheter just to facilitate healing of that anastomosis, which also correlates to return of your urine control. So this next video is actual intraoperative footage of a prostatectomy. So the prostate's been removed and the bladder neck is here. I have my two robotic arms, which I'm controlling at the console. So I'm able to twist and move and articulate in a very small confined space in a manner that I would not be able to do open. This is speeded up about 1.5 times. So this is the urethra. This is the end of the urine tube that was separated from the prostate. The nerves that were spared in this patient are here on this side and here on this side. So this gentleman actually had a nerve-sparing approach and had return of his erectile function. So with these sutures, I'm slowly starting to bring the bladder down to the urethra. First, I place the sutures so that both structures are secure, and then as I place more sutures, I slowly start to tighten them up. The bladder comes down to, we'll see at the end, both will be together, and it's a watertight closure. So when I'm typically done with this, I will have my assistant who's at the bedside and the catheter is in, they'll go ahead and they'll inject fluid into the bladder, and I can visually watch to make sure everything is watertight and sealed, there's no leakage, which again is indicative of you having a good anastomosis and getting good urine control back. The entire operation takes about 2 to 3 hours. This anastomosis, see, I've put those sutures in and now I'm starting to slowly, we call it parachuting down. I'm bringing the bladder neck down to the urethra because I put my posterior layer of sutures in. So the anastomosis probably typically takes 10, 15 minutes. So structures that we look out for, the tubes coming down from the kidneys, the ureters, they come down to the base of the bladder here. So one thing we want to be cognizant of when we do the anastomosis is I don't want those sutures to block off those ureteral openings, or that would cause your kidney to be obstructed and you would wake up having lots of pain. So those are typically, once I open the bladder neck, I can either look in and see both ureteral orifices, make sure that they're intact. Sometimes if there's a question, we can give you a dye, indigo carmine or methylene blue, that comes out blue as blue urine, so we can identify where both openings are. Or lots of times I'm just so far away from the trigone and bladder neck, and having done very many of these, I'm confident that those structures are far away and we don't have to be concerned about them. So we're just wrapping up here. I've got pretty much probably 85–90% of this anastomosis done. We're just finishing up on this left side here. So the catheter with the robotic approach, I've gotten to start taking out the catheter at about day 6, as opposed to the 14 days, 15 days with the open approach. There are some people who try and take it out earlier. What I've found is that when we try and take it out too soon, there's still a lot of swelling, there's still a lot of edema in that area. And if we take it out too soon, the anastomosis is tight, but with all that edema and swelling, guys may go into retention and not be able to pee and come back to the office, have a catheter placed until that edema and swelling resolve. So I've typically found 6 days is the sweet spot where the majority of guys do fine, the post-operative edema has resolved, and they're ready to have the catheter removed. So it's a minimally invasive approach. We're not making a big cut or incision. Across the abdomen, there's several 8-millimeter holes. Through those holes goes a port or a cannula. And through that port or cannula goes the instruments. So the robotic portion is connected to those instruments outside and above the patient, probably by a foot or two. So when you wake up, you just have the small 8-millimeter port sites, and then one of the port sites, the camera port site, will make a little bit bigger to take out the specimen, depending on how big your prostate is. So these are dissolvable sutures, typically on the order of 10 days to 2 weeks. These things will dissolve and the connection will be healed. So what we first do when we start the case is establish a pneumoperitoneum. So what that essentially means is we're filling up your belly with CO2. That gives us the space to work. There's a light on the camera that lights up the space, and we can control the intensity of the light so we can see adequately. I have an assistant at the bedside, so one of the port sites will be a port site that my assistant will work through. So she will come in with a little suction to improve my visibility, suck up blood that collects. So in the operating room, I can see when I'm looking in the console, but in the operating room, there's several screens up that the people in the room can see. My assistant can look up and see the operation as well. So some of the advantages to the robotic approach are there are less complications, less risk of bleeding, less need for transfusions, less post-operative pain, and essentially you get out of the hospital quicker. I would say 90–95% of my patients who have an uncomplicated procedure are going home the next day. And on average, depending on return of your urine and control, most people are getting back to their regular activities on the 2 to 4 week time scale. So we're going to go over some data regarding the 3 goals we discussed earlier, which is cancer control, return of urinary function, and erectile function. So this chart is just showing some of the differences between the open approach and the robotic approach and laparoscopic approach, and measured by rates of positive margins. And what this data is indicating is that with an open approach or straight laparoscopic approach, your chance of having positive margins or potentially cancer left behind are slightly higher. And I think that's a result of just your ability to see and your visualization. You know, we were talking about an open procedure when you're standing above the bed by 5 feet versus a 3D high definition camera, which is inches away from where you're operating. In terms of urinary control, so typically what we see is you come back to the office on day 6 to get your catheter taken out. Most guys at that time can experience some degree of stress incontinence. So leakage when you cough, you sneeze, you bend down to pick something up. That typically resolves in the post-operative period with the use of Kegel exercises to strengthen your pelvic floor. So what I tell patients is Kegel exercises before the operation when you're going to the bathroom, try and stop your urine stream midstream. The muscles that you use to stop your urine flow midstream are the muscles that you'll use doing Kegel exercises. So with the use of Kegel exercises in the postoperative period, the data that I usually quote guys are that by 3 months, 85% of guys are getting back to their preoperative urine control state and not needing pads. By 6 months, it's 95% of guys getting their control back, not needing pads. And this last slide is just going over the rates of return of erectile function if a nerve-sparing procedure was performed. So the 2 most important factors for return of erectile function after the procedure is, number 1, your extent of cancer. If your cancer, based on our clinical staging and workup, is confined to the prostate, not near the areas where we depicted the nerves were, then we can do a nerve sparing. The second factor is what your erectile function was like before the operation. So that dictates whether we can do a nerve sparing or not. And the number I basically quote guys with all comers, guys who have good erectile function, guys who are able to have nerve sparing, is 50% of guys at 1 year are getting back to their preoperative erectile function state. So this is just a compilation of just the differences between open and a Da Vinci prostatectomy in terms of cancer control, the days the catheters are in, complications rates, potency rates, blood loss, and days in the hospital. Again, cryotherapy is not really a common treatment option for prostate cancer. It's done probably more commonly out of the country. Mexico, there are some places that are doing it. Canada, they are. You know, the concern with cryotherapy is it's less precise. They have a higher rate of complications and injury to the rectum. And it's just the nature of which the procedure is done. So basically, similar to the prostate biopsy, you're using an ultrasound in the rectum to localize where the prostate is. And then you're placing these probes directly into the prostate, which are freezing the tissue to kill the tissue and the cancer. Hormonal therapy is usually a treatment option for individuals who have more advanced disease. So if the cancer is outside the prostate, your PSA is rising, prostate cancer needs testosterone to be able to continue to grow and spread. So one of the treatment options are inhibiting your body's ability to produce testosterone and therefore removing the fuel for the prostate cancer. That most commonly is done medically with medications, injections that we can give that stop the signals from your brain coming down to tell the testicles to produce testosterone. It also can be done through castration and removing the testicles. Hormonal ablation and hormonal therapy, whether it's orchiectomy or medical means, is typically not a cure for prostate cancer. As soon as the medication is withdrawn, the prostate cancer can grow again and potentially spread again. And also there tends to be a risk of prostate cancer cells getting used to the fact that there's no longer testosterone in the body, and the cells will become adapt to that and grow anyway. That's called hormone refractory prostate cancer. So this is typically a treatment option for guys who have advanced disease, and we're just trying to slow the cancer growth down and get the cancer under control, mostly elderly patients with advanced disease. Side effects of hormonal therapy are hot flashes, decreased libido, you no longer have testosterone, impotence, breast tenderness. And then chemotherapy is usually for patients either presenting initially with high stage and grade disease, or patients who have that type of cancer that despite the hormonal therapy and ablation, the cancer starts to grow anyway. And that's it. Appreciate your time and attention.